Hello and welcome to a special edition of Bariatric Care, the podcast, and your Thursday edition of Bariatric Care Live. I don't usually post the Thursday Bariatric Care Lives onto the podcast, but I am today because this is a continuation of a very important topic, very important to me and hopefully very important to you. And again, I urge you to share this information with other people you know who may suffer from obesity, and for sure, all the people you know who are in the bariatric field as professionals and or patients. So, we're going to continue discussing the article that explains the findings by a group of weight loss physicians in California who did a very large study on a very large number of people about weight loss and the findings that they had. So if you missed the first part, then I encourage you to go back and watch the previous video, listen to the previous podcast episode, because what I'm doing here is sharing their findings related to the disease of obesity. And basically, to catch you up to speed, this group of physicians, they were not bariatric surgeons, they worked in medical weight loss. And they found a medical weight loss program. It was basically nothing but liquid. And the patients lost weight very, very rapidly. In fact, so rapidly that it was faster than the rate at which patients lose weight following bariatric surgery. But what they found were things that absolutely shocked them that they didn't know about. And they admit that most physicians don't know about these things because they don't ask about these things. And while we understand that physicians are trained to do medical things, having an awareness that there's more to the disease of obesity than the biological aspects would be extremely helpful to patients, because then physicians could find out other underlying issues that are emotional, psychological in nature, and if so, they can refer them to people who are trained to deal with those aspects. That would lead to a much fuller, robust weight loss program, and people may have more success, not only with weight loss, but primarily not dealing with weight regain. All right, so I'm going to continue on. So this article, again, is written by the physicians who admitted they found out a lot about obesity that had nothing to do with the medical aspects of it. So the doctors say, to put it plainly, in regard to obesity, we, the doctors, have seen that obesity is not the core problem. Imagine doctors saying that. I wanted to shout for joy. They say obesity is the marker for the problem and sometimes is a solution. This is a profoundly important realization because none of us expects to cure a problem by treating its symptom. So what they're saying is, wow, for a lot of our patients, it turns out that obesity is a byproduct, is a result of a way that people are working to solve some of these psychological issues, these issues related to trauma in their early childhood. Now, how does that work? We'll talk about that more in a little bit, because they're saying for a lot of people, obesity is a solution to protect them from further emotional and maybe physical problems, pain, being taken advantage of. So they said none of us doctors expected to find this, but we certainly can't treat or cure a problem by treating its symptoms. We have to treat the problem. So they're saying that for some patients, obesity is a symptom of the problem. It's an outcome. Let's go on. We'll find out more about what they say. So the doctors say, given the nature of our observations about the causes of obesity, repeatedly documented in thousands of responses to our pre-programmed questionnaire and in more than 50 videotaped interviews, it was inevitable by the early 1990s that we revised our program to fuse two separate goals: weight loss by supplemented fasting and helping patients identify and resolve the life experiences underlying obesity. To these doctors, I applaud, I applaud, I applaud you. And I would like to encourage everybody, all professionals, whether you're in the weight loss field or not, but if you're in the medical field, you're dealing with people who struggle with weight issues for sure. Recognizing that the treatment of obesity needs to involve both the changing of habits in terms of caloric consumption and exercise, but also to help patients both identify and resolve the life experiences underlying obesity. We are missing a huge, huge component for a lot of people by not looking for this. And I work really hard to try to treat these issues with my patients and encourage other practitioners to recognize and either treat or refer out for these issues. The doctors continue. This is interesting. They say by far, the easier of the two goals is the medical management of supplemented absolute fasting. It's easier for them to deal with the weight issues. We can give them a diet. We can give them a liquid diet. You can have bariatric surgery. You can follow any kind of medically supervised diet or even a fad diet, but it's not going to stick unless you deal with the other issues as well. And they're saying the diet part is a whole lot easier to address than the emotional part. They go on. By contrast with the simplicity of fasting, so they're saying this, the fasting part of this program is the simple part. They're saying the 2-hour group meetings of the program, so they do 2-hour group meetings with all of their participants. That's a complex endeavor that is difficult for some patients to engage in and is difficult to train staff to pursue vigorously. So in other words, it's a whole lot easier to focus on the food, the consumption, the lack of consumption, the exercise than it is for both patients and professionals to work on these underlying issues. The doctors continue. By the mid-1980s, we had learned that our initial goal of teaching people to eat right was totally irrelevant to obesity. What? Although it seemed a reasonable thing to do when we didn't know what to do. So they're saying, you know what? Our initial goal, we thought if we teach people to eat right, we put them through this liquid diet and then we teach them to eat right, all will be well. Seemed reasonable. And isn't that what we do with medical weight loss and even bariatric surgery? It's let's have this surgery, you'll get that weight off, we're going to teach you to eat right, and you'll be on your way, all will be well. It's not the case for a lot of people, right? Seems reasonable. Here's what the doctors say. In retrospect, we should have known better because most of us knew, check this out, that overweight, middle-aged women commonly knew enough about calorie content to give a dietitian a run for his or her money any day of the week. And I find that very, very true for most of the patients we deal with in bariatric surgery. Most patients have a pretty darn good understanding of calories, nutrition, not all, but most people, because they've been on every dang diet there is. They've counted calories most of their life. So most people have pretty good understanding of this. I'm going to skip that one. I'm reading from some slides that I use. Okay, so the doctors continue. In the course of detailed interviewing of about 2,000 obese patients over the past 20 years, we're not talking about 10 people. We're talking a lot of people that they interviewed in depth. So the patients gave them all this information and they said, we repeatedly noted several recurrent findings. So this wasn't just a few people saying this. This was a lot of people. They say it is rare for anyone to be born obese. Of these 2,000 adult patients, only one of them, 1 out of 2,000, was born overweight at 14 pounds. That individual was born to a woman who weighed 550 pounds. She was slender throughout childhood and adolescence until age 20, at which time she married an alcoholic and suddenly began massive weight gain, ultimately matching her mother's weight. So the child, who was born at 14, remained slender. Then she married somebody, there were issues, and she gained a lot of weight and eventually matched her mother's 550 pounds. So they're saying when people say I was born fat, it's not true. It's kind of a defensive thing, saying I didn't stand a chance. I was born fat. No. The doctors say obesity indeed runs in families, as does speaking the same language. It is the distribution pattern of body fat deposition that is genetically determined, not its presence. Now, I'm not a physician, so I can't say, how accurate that is medically. But what they're saying here is that, yeah, obesity runs in families, but it's about where that fat is going to land. Like if you're from a family of big bottomed women, you're likely to have a bigger bottom. If you're from a family that carries their weight in their middle, it's more likely you're going to carry your weight in the middle. So it's where the fat is distributed in the body that's genetically determined, not whether or not you're going to be overweight. And what they're saying about this thing that obesity runs in families as to speaking the same language, well, you live what you learn, right? If you grew up in a household that speaks Spanish, you know how to speak Spanish, Italian, Portuguese, whatever it is. If you learn to eat poorly in the family you live in, you probably eat poorly until you make a decision to make those changes. The doctors say major weight gain is typically abrupt, episodic, and life event related. What do they mean? Major weight gain is typically abrupt, episodic, and life event related. They continue. The age at which weight gain first began is critically important because it allows us to inquire why it began then. Some patients will know and others will not want to know. But this is an essential point not to be dropped because of patient avoidance. So they're saying usually there's something that's correlated with the age at which a person has started gaining weight. And it's important to dig into what that might be because a lot of times people will be able to pinpoint something that happened in their lives. Not always, right? But more often than we might think. The doctors who wrote this article and did this research say obesity commonly is beneficially protective. Sexually, physically, and socially. This is an uncomfortably difficult point for many non-obese people to accept. So they're saying here that, a lot of people who haven't ever struggled with weight, and they have those absolutely incorrect misperceptions and the stereotypes about people who carry extra weight. Like they're just lazy or they don't care or they, whatever those misconceptions are, they're not intelligent. All those things that are inaccurate as heck. They don't work hard. Not true for the majority of people who are overweight or obese. They're human beings like the rest of us, people who suffer with addictions or the disease of obesity or a lot of chronic diseases. They're intelligent, they're hardworking, they get up and go. So the people who don't understand it, right? But what they're saying is what they don't understand and what these doctors didn't understand is that a lot of times carrying extra weight makes somebody feel safer from a sexual perspective. Socially, it helps them. It just kind of gives them an emotional barrier. Major weight loss may present a significant threat, usually to the person involved, but sometimes to others. Why is that? Well, when you lose a lot of weight, emotional issues may surface. And I have had a lot of patients validate this to me. There are times I've gone onto Facebook, and you can do this yourself. Try it out. Don't take my word for it or these doctors, but go online and ask your peers or your patients, you know, you know, what is it you feel? How have you felt emotionally when you've lost a significant amount of weight, or people who have regained in particular? What happens? What do you feel emotionally when you lose weight? And people will say, I'm afraid of how I feel. I don't like the thoughts I have. I feel very vulnerable. I'm scared. I don't like my thoughts. I don't like where my mind goes. So that is threatening to a person, right? So maybe, remember, 1 out of 3 women is sexually abused. So I'm going to assume that 1 out of 3 of our bariatric patients fits into that category. So if 1 out of 3 of our bariatric females or 1 out of 4 of our males loses weight, then it would make sense that they are fearful that they may be approached in a sexual way. Another aspect of childhood sexual abuse is promiscuity. So some people, when they lose weight, are afraid they will go out and be promiscuous. So dealing with that underlying issue is important so that the patient doesn't regain weight, so that they don't feel like they're being preyed upon sexually, or so that they don't sexually act out. Not all, but enough. So the doctors changed their program. So the main work of their program enters personal territory that is comfortably off limits to polite people. It is therefore difficult and demanding, though conceptually simple. Doing the work in groups is essential because of the implicit support of the group and because patients quickly learn from each other's self observations. So, what they're saying is, you know, what we talk about in these groups, these 2 hour group therapies as part of our program, is not stuff polite people talk about. They don't talk about, is there sexual abuse? Was there trauma in your childhood? What kind of trauma? What was the nature of the trauma? Was there abuse? It's like, ooh, that's not polite to talk about. But if we're going to help our patients, by God, we better be willing to talk about with them, right? And the people who participate in these groups absolutely benefit from the presence and the support included naturally because they're in a group with other people who've experienced the same kinds of things. I absolutely love group therapy. And in the fall, I'm starting an online group therapy program for bariatric patients who would like to participate and deal with some of these deeper issues. I already do a class called Gain While You Lose, which is an amazing class basically based around this kind of stuff, although it's not group therapy. And didactic education, while it increases awareness and helps people start to do some inner reflection, isn't enough to help people work through it. You need some therapy. So the doctors go on to say, to the degree that counselors pose meaningful questions to the group members and insist on answers to the questions asked, and not to some enfeebled version of their questions, they are successful. What does that mean? I'll tell you in a minute, because they go on to say, to the degree that people teach by lecturing, which is like my Gain While You Lose class, you fail in treating these issues. The task is to help people discover what they already know at some level, and then to use that information for their own benefit. So a lot of people keep this awareness of having experienced some neglect as a child, or maybe some kind of abuse. Maybe they didn't know it was considered neglect or considered abuse. That was the case for me for many, many years. I didn't want to acknowledge the neglect and abuse in my home. And it took me a long time through a severe eating disorder, through an addiction to food, through an addiction to alcohol and other drugs, in and out of therapy until I was ready. And the pain was so great that I was like, fine, let's talk about it. And by talking about it in group therapy and in individual therapy, I learned to accept the reality of what was, to accept the reality that I can change my present. I can change my thinking. I can change the way I feel about myself. I can put a lot of pieces together and I can make different choices in my life today. That's the benefit of group therapy. And then I used all that to my benefit to change my life. These doctors share some of the questions that they recommend people asking in group therapy. So here's some of the things they say to illustrate the process. Some seemingly simple questions may be offered as examples, understanding that this works best in small groups and initially will be stressful for everybody, including the group leader, because it's like, these are tough issues. But after doing this for as many years as I have, it doesn't stress me out. It brings me great joy because I know that by going through the pain, people can release it and make different choices. Excuse me. So here are some of the questions they ask people, and you might want to ask yourself, why, not how, do you think people get overweight? What are the reasons you think people become overweight, obese? We know how, but what are the reasons you think? How old were you when you first began putting on weight? What do you think it was about that time in your life that you started to gain weight instead of a few years earlier or maybe a few years later? Another question. Sometimes people who lose a lot of weight regain it all, if not more. When that happens, why do you think that happens? What are the reasons you think people might regain weight? And then another really tough question to ask yourself is, what are the advantages of being overweight? And I know at first you might go, what, are you kidding me? There are no advantages to being overweight. But I suspect that if you really get down deep, if you struggle with regain after regain after regain, you might discover that there are some reasons you continue to put weight back on. So the researchers here, the doctors, say patients' answers to these questions are staggeringly counterintuitive to conventional thinking about obesity. Moreover, their answers have been consistent over the many years we've posed these questions in group sessions. So these doctors were shocked. They were like, we did not expect to hear what we heard. And furthermore, what we heard over and over and over and over again for years and years and years by different patients. So it's not a bunch of, malarkey. It's not, well, every now and then that happens. No, it's consistent. For instance, they say, answers to question 1, why do you think people get fat? Routinely are stress, depression, people leave you alone, men won't bother you. There are, of course, they say, occasional escapist responses like, I just like food. So when I work with people and if I hear an answer like, I just like food, I'm like, well, I'm sure you do like food. Let's go deeper. What else? What else, causes obesity? So stress, right? Emotional eating. I eat in response to stress. Life is stressful. That's not going to change after bariatric surgery. So, what people who regain in relation to stress need are coping skills to deal with the stress. If you have depression, then you need to have the depression treated as well as the, change in the behaviors. But what's the depression related to? Is it related to underlying trauma? But I loved it that people were like, people gain weight because people leave you alone then. They don't bother me. Men aren't going to bother me. This were obviously women, right? Or maybe not. I don't know. All right. The doctors go on to say, in that case, the following response to the answer for question 2, which is, how old were you when you first began putting on weight? Why do you think it was then and not earlier or later? So can so a lot of people will say, you know, I just did, or I don't know, that's just when it happened. So a question to say is, really, can you tell us maybe why you suddenly, like if they say, I just like food. So if you say to them, if the therapist says, we've probably always liked food. So why do you think it was at age 22 that you first started putting on weight? Or 37? I mean, if you've always liked food. So kind of digging deeper, digging deeper, digging deeper, making people get more and more honest on a deeper and deeper level. The researchers report responses to question 3, which is sometimes people who lose a lot of weight regain it all. When that happens, why do you think it happens? They said the responses are always a version of, if you don't deal with the underlying issues, the weight will come back. That was from the patients. The patients were saying, if you don't deal with the underlying issues, the weight will come back. 100%. I agree with that. And then they say, check this number out, about 60% of the time, over half of the time, somebody in a group also proposes that regain occurs because major weight loss is threatening. What is threatening to these patients about major weight loss? The answers that I shared with you that patients give me. I'm afraid of how I feel. I'm afraid of what I think about. I'm afraid about, I'm not comfortable with my feelings. And the answers they got to question 4, which were, what are the advantages of being overweight, repeatedly fell into 3 categories. 1, obesity is sexually protective. What do you think about that, right? It protects me sexually. People don't want to come near me. 2, it's physically protective. In other words, I can throw my weight around, is the answer. And thirdly, it's socially protective. People expect less of you. Those responses came from the patients in these groups. I didn't make this up. These researchers didn't make this up. These were coming from hundreds of patients over years consistently. So the doctors say, ultimately, we were forced to recognize that patients in a supportive setting speak of things that we ourselves might find it easier not to know. This embarrassing recognition exposes the tempting opportunity that a physician or group leader has to become part of the problem by as authenticating obesity as a medical disease, when it's actually the somatic inscription of life experience into the human body and brain. So what the doctors are saying here is like, we had to just throw up our hands and say, you know what? When patients speak so honestly like this in a group, it's embarrassing to us as physicians and group leaders, but we had to recognize that sometimes we play into the problem. We're like, this is a medical problem. This obesity is a medical problem and a medical problem only. So they can help further the problem because they don't help patients see that, yeah, there are tremendous medical aspects of this, but there's a whole other layer to this, and we need to deal with it. It's about, when they say inscription of life experience, it's like, this is what happened to me, and this is how it's affecting me physically and emotionally. The doctors say what we have learned about obesity has been more widely applicable in everyday medical practice than we would ever have contemplated. The general principles underlying the unconscious compulsive use of food as a psychoactive agent are common to any of the addictions. I'll come back and explain this in just a minute. But let me continue because they say the psychoactive benefits, how it affects our brain and our actions of food, are profound, but not curative. People will tell you, sit down, have something to eat, you'll feel better. Sit down, have something to eat, you'll feel better. Food makes people feel better. Hunger is nowhere to be found in that saying. Sit down and have something to eat, you'll feel better. Whether we're talking about the next mouthful of food, these are the doctors talking now, the next drink of alcohol, the next cigarette, the next sexual partner, or the next dose of whatever street drug we might buy, the concept is equally applicable. It's hard to get enough of something that almost works. That is such a profound statement. It's hard to get enough of something that almost works. So we drink, we smoke, we gamble, we buy food, sex, pornography, and it makes us feel better. It's a psychoactive agent. It changes how we feel. And it almost works, right? But it doesn't cure the problem. It makes us feel better temporarily. And then typically after engaging in excess of any of these things, we feel worse. The doctors say slowly we have come to recognize that overeating isn't the basic problem. It's an attempted solution. And people are not eager to give up their solutions, particularly at the behest of those who have no idea what's going on. So we have therapists and psychologists and physicians and bariatric surgeons and dietitians and exercise people who really might not have any idea of all this stuff saying, you need to lose weight. 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 Why can't you lose weight? Why aren't you sticking to this? And if they don't have any idea that this is protection, they're missing the problem, right? Not for all, but for a lot. These doctors say obesity is not the problem for a lot of these people. Obesity is the consequence, the marker for the problem. Much the way that smoke is the marker for a house fire. You see smoke, you assume there's fire, right? They're saying if you see obesity, you need to assume that it's more than just medical, because it is for so many of these patients. That's what these doctors are saying, not me, although I fully agree. And it fully supports the work I have done as a practitioner, as a therapist, as a psychologist for well over 20 years. Same with cigarettes, same with pornography, same with sexual addiction, same with alcoholism. These things are definitely problems. Obesity is a problem, right? It leads to other problems. But for a lot of people, it's a symptom of the problem. The symptom and the problem need to be treated, but you go to the doctor and what do they want to treat? Let's treat this weight. Let's treat this cigarette problem. Let's treat this alcohol problem. We got to do that. But if we want it not to lead to another problem or a regain or a relapse, then we need to treat the underlying issues as well. I hope you're getting the point, right? I'm almost finished here. These doctors say often enough, obesity is even the solution to problems that are buried in time and further protected by shame, by secrecy, and by social taboos against exploring certain areas of human experience. So it's like, okay, all this crap happened. I'm embarrassed. I'm ashamed that it happened. And then nobody else wants to ask me about it. So I'm not going to talk about it. I don't want to feel it either. So it just gets buried and buried and buried. Come on, professionals, help our patients dig deep. Dig deep. Let's help them clean out this emotional closet that's been shoved They're standing in front of it, pushing it so the door doesn't open. Let's help them carefully and compassionately open that door so they can let it out and not have to put so much energy into holding back all these emotions related to past traumas. And yes, let's treat the weight as well. It's got to be multifaceted. Overall, we have found and documented that the antecedent life experiences of the obese are quite different from those of the always slender. So they're saying people who, struggle with obesity, their lives were different in a lot of ways. They were teased, bullied, and all those other perhaps adverse childhood events. Some of our patients, say these doctors, regain all of their weight and others do not. The question we posed was, what are the differences between those who regain and those who do not? So they were like, okay, so we have this huge population of people. Some of them lose weight and don't regain. Some of them lose weight and do regain. What's the difference? And I will ask you, as a patient population of people who have had bariatric surgery, we know some people maintain that weight loss and some people regain. What's the difference? I'll bet it's not much different than what these doctors found out. So check this out. This is really, really interesting. These doctors identified two major predictors of regain. One, a history of childhood sexual abuse, and two, currently being married to an alcoholic. What? So this is just my experience. I'm going to broaden the history of childhood sexual abuse. People who regain, in my experience, it may not be sexual abuse per se, but have experienced any kind of abuse, neglect, or have witnessed it. Those people who, if they haven't worked through those issues, tend to be the regainers, in my experience. And also being married to an alcoholic and or drug addict and or sex addict and or any kind of major work addiction, any kind of addiction, being married to somebody who's an addict. Why? Because there's constant confusion in the home, right? A lot of stress. What do people say leads to regain? Stress. All right. Today, the prevalence of obesity is rapidly increasing in children. This is back to the article in the doctors. Although our experience with obese children is quite limited, so they're like, we don't deal with kids. We are impressed by the number of adults who date the onset of their initial weight gain to coincide with parental loss in childhood, usually by divorce. Usually by divorce. Do you know how many of the bariatric population, of the entire population, has been affected by childhood divorce or childhood parental loss in childhood? A lot, right? Our divorce rates are over 50% and over 70% for people who've had bariatric surgery. These doctors say this correlation with parental divorce has escaped general attention. But if you keep in mind, that was one of the questions in the ACEs study, right? And then these doctors confirm a search in Google Scholar using the phrase childhood obesity divorce quickly indicates its presence in the literature. So a lot's been written about this. Given the high prevalence of divorce in the US, we suspect that McDonald's may be a more comfortable explanation for childhood obesity, although it obviously misrepresents mechanism as cause. In other words, we say there's a lot of more fast food today than there was in the past. But there's also a lot more divorce, right? So what's the cause? They're just throwing that out there. The doctors sum up by saying, we have slowly learned that our average patient, on the one hand, wants very much to lose weight, but on the other hand, often has significant unconscious fear about the changes that major weight loss will bring about. And that absolutely, absolutely corresponds with what I have seen with our patient population. Everybody I do an evaluation on for weight loss surgery absolutely wants to lose the weight. Without a doubt, that is 100% true. I also agree that a lot of people have a lot of unconscious realities related to things they don't want to think about, things they don't want to have any feelings in relation to, right? So I think that a lot of people have some fear about the changes that weight loss will bring about. They've probably lost weight before. Maybe they've been uncomfortable. Who knows? But I do believe that's true. Everybody wants to lose weight, but there's a lot of fear about life after the weight loss. And so the title of that article is Obesity: Problem, Solution, or Both? And to sum up their article, people are not eager to give up their solutions. If this is what has brought me some sort of peace, even though I really want to lose weight, I feel protected. This is a solution for me. How likely are they to give it up, especially if they don't have the awareness of that's what it is? So please take this information, process it, consider it, talk to others about it, talk to people in your groups online, share this article. I will put the name of the article in the show notes. I will also put the name of the article on the Bariatric Care Facebook pages and everywhere. But it is, again, obesity, problem, solution, or both. So please read it, think about it. If you need to talk to a therapist, please get yourself a therapist. What kind of a therapist? A marriage and family therapist, because a lot of this stuff originates in childhood. Marriage and family therapists understand family systems dynamics. Just trust me on that. If you have any questions and you want to contact me personally, you are always welcome to do so by emailing me at cstapletonphd@gmail.com. It's a lot to think about. There's a lot of reality in there. So again, please, I do ask you to share this podcast, to share the article with everybody you know who's in the weight loss community of any sort, because we need to give people the help they need to assist them not only to lose the weight, but to keep the weight off. And I will be starting a group therapy program in the fall. I am only licensed in a few states, but there's an organization called SciPact, which is allowing therapists to work in other states as well. So if you're interested but don't live in Georgia, South Carolina, or Virginia, where I am licensed, there's still a chance that you can be part of the group therapy if you'd like to be. Also, I'm doing another Gain While You Lose class in the fall. So just watch on my Facebook page or Instagram for that, and go to my website, ConnieStapletonPhD.com. Okay, I've taken up enough of your time for today. Thank you for listening to this. I think it's critical information, and I'm grateful to be sharing it, but even more grateful that you're listening. All right, you guys, have a great weekend. And as always, remember, it's your health, which is your responsibility this day and every day. I'll see you next week. Bye-bye.